The Community House Calls program of Caseworkers and Cultural Mediators, or CCMs, has been operating for 25 years at Harborview Medical Ctr, a county hospital in Seattle, Washington. Here, a highly skilled team of 8 CCMs engage patients in a culturally tailored manner to facilitate their understanding of their diagnoses and treatment, and to help them navigate the complexities of chronic diseases or cancer diagnosis. They focus on advocacy, mediation, navigation, education, case management, and interpretation. The most effective way to understand this program is to see it in action, using the following cases. Consider the following example. A 74-year-old Argentinian man, just diagnosed with lymphoma, was waiting staging and preparation for chemotherapy. The oncology team, using trained professional interpreters, found him to be agitated, uncooperative, remote, and disengaged. They contacted the House Calls program for advocacy and cultural mediation. Jose, the CCM, introduced himself and then spoke with the patient, who complained that every day for a week he was awakened, poked, and prodded for blood draws, and asked the same questions, and no one really seemed to be listening to the answers. No one ever told him why they were there, what they were doing, or what they were finding. They just kept asking him how he felt. The oncology team, concerned he was depressed and blasé about his therapy, felt he would not do well given what was ahead. The patient was underweight and needed to eat to prepare for chemotherapy. Unfortunately, to add insult to injury, every morning scrambled eggs were delivered to his bedside, and he hated scrambled eggs. He longed for a burger, but it was not on his menu. Again, no one seemed to be listening.
I met with the attending oncologist and I asked her about his diet. I then asked her to change it to something he will eat to help him gain weight. Once the attending approved it, and I spoke with the charge nurse so she knew, and then contacted the hospital dietitians. That simple change was the first step towards seeing that I could advocate for him and change things. This helped me establish trust, and all I did was arrange for a burger and a breakfast eggs sunny side up. Then I confirmed with his sons the patient's frustration with his care and his hopelessness. The son agreed that this was exactly how he felt. While the son spoke fair English, he was not fluent, and so his expression and comprehension were a significant problem. But the medical team couldn't tell. Now I had the son's confidence and my empathy and ability to see his father's situation and encouragement to advocate in their behalf. There were important cultural nuances. For example, he was from Argentina, and the Spanish usage by Argentinians can vary considerably. The Argentinians are Eurocentric, and their dialect is Castilian. For example, the Argentinians use the word podrido for ill, but elsewhere in Latin America it means putrid or rotten. So soy podrido can sound to non-Argentinians extreme, like self-disgust and despair, but that was not his intent or his meaning. I continued to get involved with his case, to meet with the team, and with him, and also with his son. I arranged to go with him to the infusion suite and interpret for him there. This further developed a trusting relationship. The oncology team eventually transferred him to a nursing facility in preparation for his infusions and treatment, and in an effort to gain weight and strength. He was happier there, exercised daily, met with friends. I visited him there and then communicated to the team in person and in chart notes in the medical record how he was and his comprehension of the next steps. Once he was strong enough, he then clearly expressed a desire to maximize his chance of beating the lymphoma and to get better.
CCMs advocate for patients and families, assess comprehension, cultural subtleties, and linguistic nuances, capturing this in their interpretations and notes. The CCM communicates context and backstory to the medicine and oncology teams, advocates for the patient, and helps to modify aspects of care that are creating bad faith or discomfort. The CCM understands the culture of medicine. They know by whom decisions get made, how, and when, and carefully work within the structures of medicine to execute patient-centered changes. Here's another exemplary case, a bit more complex. On a daily basis, the CCMs check the hospital census for patients who speak their language and who've been admitted overnight to the ICU. They visit the patient and their families to assess the situation. On one such occasion, a 41-year-old Mexican immigrant woman who had a successful franchise and was married to a man with a landscaping business was assaulted by her schizophrenic son. He had stopped taking his antipsychotics and was agitated by recreational drug use. In this state, he stabbed his mother in the neck, severing her spinal cord and causing massive blood loss. She was intubated upon arrival in the ER, but she was left a quadriplegic from the spinal cord injury and had an anoxic brain injury from the blood loss. After transfer to the neuro-ICU, Jose, the CCM, became involved. Jose found the woman on a ventilator, comatose and immobile. Her neurologist had twice established that she was brain dead. The ICU team felt the humane thing to do, therefore, was to begin the discussion of the withdrawal of life support. But the family was not at all ready. The family was in shock. Their matriarch, who had an active business, was now in a coma on a ventilator.
I met with the family to organize them and communicate their wishes to the team. The family kept seeing movement, tearing, and posturing, and thought she was purposeful, aware, and struggling to communicate. The family knew of a friend who had awakened from a coma after many months. Since they were people of faith, they prayed for a miracle. While they waited for this miracle, there was an older sister who raised the patient and is still living in Mexico. They wanted her to see her one last time and to help make the decisions about removal of life support. In general, the family was confused, scared, uniformed, agitated, hopeless, unrealistic, and powerless.
As grief and loss set in, so did psychomotor retardation, and the need for more time to process grief and the unfamiliar information. On the other hand, the unit team was stressed and busy, and this was a brain-dead case being tormented by ongoing ventilation and expensive care, and this needed resolution. Most importantly, the patient was being treated cruelly from the team's perspective, with ventilation and tests and drugs when it was hopeless. In the ICU, decisions need to be made quickly because things change quickly and resources are expensive. There is often tension between unit teams and families.
Studies have shown that LEP patients have less interaction with the medical teams. I help the team arrange for family conferences for regular updates. Initially, a large team arrived and large numbers of family members. It was confusion and chaos, but the beginning of communication. The family wanted to wait, wanted the sister to come from Mexico, but she did not yet have a Mexican passport, and all the while they were still praying for recovery.
The attending physician in frustration suggested a tracheostomy tube and a feeding tube to support her while decisions were being made. Jose explained the reasoning, and the family, initially aghast, agreed with the PEG and trach, since it would buy them time. In the interim, before this was done,
I asked the ICU attending to write a letter to the American government requesting help facilitating the arrival of the family member. Then I worked through my contacts at the Mexican government to get a passport in 3 days for the sister in Mexico. This is unheard of in Mexico. But on the U.S. side, in conversations with immigration, I could not get a U.S. visa for the sister since the case was futile. The family still didn't trust that ending ventilation was the best thing for her. More family conferences with the team were held for updates. I arranged to downsize the conference with fewer nurses, residents, and therapists, not directly involved in the care. Most helpful was coordinated with palliative care, who invited a priest from spiritual care to begin each conference with a prayer.
the family was troubled by what they saw in her. They felt she was purposeful and struggling to recover. The ICU attending agreed to show them what these movements really were by walking them through a detailed neuro exam and explaining what each finding meant. Jose then interpreted the process and reinforced that it was the typical autonomic reflexes and posturing that kept giving the family false hope. It was only when the family understood that what they saw was not purposeful, not intentional, but reflexive, that they were ready to let her go.
The medical team began to stop pressuring the family in every conference about a decision on life support and simply update them about her current condition and focused on the family's fatigue and emotional state. Tracheostomy was never done. When the services changed, I explained the importance of continuity in this case to the new attendant, who then cooperated and kept the previous attendant engaged in her care, and I relayed the promise of continuity to the family.
She died within 48 hours, with the family at bedside. The CCMs review the census for newly hospitalized patients in the ICUs. There are 9 ICUs at Harborview. They meet with families to advocate and mediate concordance and congruence between the medical team and the family. They know the culture of medicine and know who to speak to, when, and how. They know the institution and know which services manage which aspects of patient care and daily routines. They communicate with the medical team and educate about the culture, the family, and the patient. They discuss the end-of-life issues and coordinate with palliative care. They coordinate with sister institutions for dialysis, infusion, radiation, and more efficient workups. They work with governmental agencies, such as consulates, immigration, school systems, and DSHS. They build trust between the team and the family to reduce a feeling of being bullied on both sides. They arrange for education of physicians on cultural issues and of patients on public health and medical topics. They educate communities on prevalence of disease and medical routines. The desired outcome of this work is concordance and cooperation between the patient and the family and the medical institution, with each side understanding the medical and cultural subtleties in a case. Each side trusting that the decisions being made are patient-centered, respectful, dignified, and humane, all within a framework of a trusted relationship.